Hi, I'm Dr. Anusheel Munshi. I'm the head Department of Radiation Oncology, Manipal Hospital, Dwarka, New Delhi. I want to thank FARO. I want to thank the Radiation Oncology Association of Philippines for having invited me for this talk. So over the next 15 to 20 minutes, I shall be talking about balancing cardiac mobility with thoracic radiotherapy. What are the issues? What are the challenges? Where do we stand? The first question is, does radiation affect heart? And the answer to this question, I'm just presenting two snapshots from evidence. One is the landmark study from Derby, published in NEGM in 2013, which tells about the risk of ischemic heart disease in women after radiotherapy for breast cancer. And then I'm presenting some evidence that is recently coming up related to radiosurgery for cardiac arrhythmias. And this is proof of the pudding. This is proof of the pudding that radiation does indeed affect the heart. So the answer to this question is a big yes. Now, if it does affect the heart, what are the pathophysiological manifestations of radiation-induced heart disease? Well, chest radiation exposure can result in microvascular injury, valvular injury, dysfunction. Age-related atherosclerosis can be accelerated. Myocardial perfusion and related things can be affected. Myocardial ischemia can ensue. Pericardial effusion, pericardial constriction can happen, and so on and so forth. And there is a temporal effect as well over a period of time. For example, post-radiation, over a few minutes, you will have a clotting cascade. In a few hours and days, you will have acute inflammation, immune cell recruitment, release of pro-inflammatory mediators. And then over a period of weeks, you would land into a phase of chronic inflammation, fibroblast accumulation, and so on and so forth. Now, when we talk about thoracic radiotherapy, this could be radiotherapy related to lung cancer, esophageal cancer, lymphoma, thymoma, breast cancers, and so on and so forth. And why I'm mentioning all these sites is that the relative overall survival also varies a lot between these primaries. For example, for lung cancer, we are talking of a relatively small overall survival. Similarly for esophageal cancer, but for lymphoma and thymoma, it's more. And then for breast cancer, it could be even more in many cases. So this relative overall survival is also important when we talk about radiation-induced heart disease and its manifestation, because the more time you have after receiving radiation, the more chances there could possibly be for the radiation effects on the heart to get manifested. So I begin with thoracic radiotherapy, the site effect. What is the effect of the site on which you are giving, or close to which you are giving radiation? So I'm taking the examples of lung cancer, breast cancer, lymphoma. The quantum of the dose that is received, lung cancer generally receive quite high dose of, the heart receives quite high doses of radiation during the radiotherapy. Breast cancer, the doses are a bit intermediate. Lymphoma, again, low to intermediate doses. Survival, as I said, overall survival, lesser in lung cancer, better in breast cancer, relatively better in lymphoma also. Age, again, this is a very important thing, which is the age where these cancers usually present. Lung cancer, usually older patients, breast cancer, intermediate age, lymphoma, younger, and then comorbidities, again, very important. Many comorbidities in lung cancer patients. So that is all these put together, the onset for radiotherapy-induced effects, especially on the heart, is relatively early in lung cancer, relatively late in breast cancer, relatively late in lymphoma as well. So I have broadly split them into three: the dose effect, as exemplified by Derby, the dose time effect. Very nice publication in Red Journal in 2018. And mind you, see this lowermost line. This lowermost line is the line of no RT. That means even without any radiation, all of us, as we know, are at risk of heart disease, which keeps on serially increasing over a period of time. And yes, if you receive radiation and incremental doses, the chances are higher. And then there could be a dose per fraction effect. This is also a very important effect. So the dose and the side effect combined together result into these relative risk of RIHT in cancer survivors. Well, when you talk about Hodgkin's disease or you talk about breast cancer, relative risk or relative risk in Hodgkin's disease, these are the risks that we are talking about. For RIHT, more than 6.3, Hodgkin's disease, 2 to 5.9 breast cancer, cardiac death, 2.2 to 12, Hodgkin's disease, 0.9 to 2 in breast cancer, and so on and so forth. I've made this table to illustrate the dose per fraction radiobiology in the context of EQD2, and especially taking the perspective of lung cancer, where, for example, you have schedules such as 74 in 37, which was used in an RTOG study, dose escalation study, and you use in common practice 64 in 32, 60 in 30, 55 in 20. And then in SBRT regimes, you are using those schedules such as 54 in 3. And you would realize that the EQD2 suddenly starts posing great effects and is getting translated, for example, as you move towards the hypofractionated regimen, and if you move towards the late effect section where alpha by beta is low, you can see the EQD2 is going higher and higher and higher, and in the case of SBRT, much, much higher. So keep this in mind as we are going forward in this presentation. Hypofractionated, as I was talking about the dose per fraction effect, hypofractionated radiotherapy, again, has been found to have a kind of detrimental effect in a way on the heart compared to normal conventional dose per fraction, as has been exemplified by the letter that we wrote to JCO. The question is it that the higher and higher we go in terms of hypofractionation, we go to extreme hypofractionation, what would be the consequences? We really don't know. Presently, all that we are talking about is trying to spare the heart as much as possible, be it conventional, be it hypofractionated. What are the lessons I was talking about RTOG 617. What are the lessons we have learned from RTOG 617? It was a randomized study to study the role of dose escalation, and we all know that. We also realized in this study that cardiac toxicity was higher in the high dose arm, and higher volumes of V5, V30, V40 were all associated with worse survival. That's a very important message that came out from RTOG 617. So what are the risk factors for RIHD, or radiation-induced heart disease? Anterior or left chest irradiation location, high cumulative doses of radiation, especially more than 30 to 35 gray. Younger patients, because they have longer to live. High dose per fraction of radiation that is given to the patient, and presence and extent of tumor in or next, very close to the heart. Similarly, lack of cardiac shielding if we don't practice it during radiation planning. Concomitant chemotherapy, especially anthracycline, a big no concomitantly with chemotherapy. Pre-existing cardiovascular disease, again, increases the risk of major acute cardiac event, MACE. Diabetes mellitus, smoking, overweight, hypertension, hypercholesterolemia, all of these result in higher post-treatment MACE and other events. So what are the dose constraints that we typically prescribe for the heart? If you go by the context study, remember there were no studies of lung cancer patients in this paper. So V30 below 46%, mean heart dose less than 15 gray, what was recommended by Quantum. The Derby study was a bit more severe. It said that the risk of MACE in breast cancer survivors increases in linear relationship to cardiac radiation dose. Very strong statement. So what are the problem areas? Now this was a very beautiful systematic review. More than 5,600 patients, 22 studies, 214 cardiac dose parameters. And they did attempt to bring out some common parameters that could predict cardiac injuries, such as V2 gray, V5 gray, V30 gray, V40 gray, V50 gray, were showing significance. But the problem is that they could not identify, and this is the root of the problem, they could not identify consistent DVH parameters for survival in non-small cell lung cancer patients. And that was the sad part of it. And similarly, you have clinical studies going on. Many clinical studies, and just presenting a snapshot of the important ones. And each of these studies, unfortunately, gives us a different parameters. Some studies say mean heart dose more than 20 grays detrimental. Some say, okay, V5 is not associated with overall survival. Some say heart V35 more than 10% is important. Some say heart V40 is associated with overall survival. So that is the heterogeneity that is existing in the literature, and that creates problem in giving a uniform prescription or a uniform guideline to everyone. I think it's time that we move beyond mean heart doses, definitely. And we are now moving on to atlas-based contouring. And I'm just presenting one example published in the Green Journal, Cardiac Contouring Atlas, in which you have various segments and various models and various portions. For example, you have anterior, lateral, apical, septal, inferior, and then it is divided into various subsegments and so on and so forth. Similarly, for the coronary artery, you have the left anterior descending, circumflex, and the right coronary artery. And each of them is again divided into proximal, mid, distal, because we know the radiation in different cases, in different patients, can affect different portion of the vessel. So it's probably better to contour each portion separately so that you can tell the planning system that this is a portion that you be especially careful about. I'm just presenting you this snapshot to illustrate that how complicated it can become, and how sometimes challenging for the radiation oncologist it can become if we start contouring different portions of the heart, although this is the way forward. But just giving you a snapshot. So, for example, studies have shown decreased overall survival if the base of the heart dose is more than 8.5 gray. Decreased overall survival if the pulmonary artery V40 gray is more than 80%. Similarly, pericardial V30 more than 29% associated with worse survival. Max dose to RA, AV, and RCA more than 19.5 gray associated with worse overall survival, and so on and so forth. So each structure, different constraint, different parameter. And it may sound overwhelming, but probably we have to now, as radiation oncologists, evolve forward, and this is probably the way forward now. We too, in our own institution, have done some studies to assist and aid the clinician in drawing the coronary vessel, and this is the technique which we propose, the coronary strip technique, in which we take the entire angle in which the coronary artery lies and control it as a coronary strip. And of course, follow-up of these patients post-radiation is also very important, which can be done by various techniques, including echo, cardiac MR, cardiac CT, stress echo, and so on and so forth. Many people think machines matter, but all the modern machines, I feel, all the modern machines are good enough, capable enough to spare the heart, provided we are doing diligent contouring. We are putting all our effort in delineation of the target, delineation of the OR, delineation of the heart diligently and meticulously. Another situation that we can sometimes land in, patients with cardiac pacemakers. Again, quite a bit of literature on this now. So each patient has to be carefully dealt with, trying to spare the pacemaker body, the lead, the electrode, trying to give it as minimum dose, less than 5 to 10 gray, as minimum dose as possible. The other challenge, as we talk about sophistication and advancement in terms of sparing the heart, is the challenge of, for example, gating, or for example, taking into account the motion of the heart. So as this diagram would illustrate, it's much more possible, much more feasible for radiation oncologists to take into account the motion of the breathing and to account for it, because it's much, the frequency is around 18 or 20 per minute compared to the heart, where it's beating around 72 or 80 or sometimes more per minute. So to account for cardiac motion and cardiac position at a particular time frame, and then fine tune your radiation according to that, is a bit away as we see things right now, but who knows, in future this might come up in a big way. So as you would have realized till now, the issues with literature are most published work comprises small, retrospective, mostly single center studies. Varying endpoints are used in studies. Large variation in pre-existing cardiac disease, comorbidities, RT technique, and use of chemo in test population. So a lot of heterogeneity happening there. So what's the way forward? Design prospective, sufficiently powered studies in different sites, have common agreed cardiac atlases and robust QA, which are used in all the studies that we are doing, so that we have a uniformity of data that we're generating, and do data pooling between centers. So these all things are very, very important if we want to try to optimize and try to save the heart as much as possible from the effects of radiation. I want to thank all of you for a patient hearing. Thank you very much.